So the next speaker is Tal Arulampalam that will speak of the barrier to adoption benefit of standardization of procedures.
Thank you very much, Chairman, ladies and gentlemen. I'm going to talk to you about the barriers to adoption of some of these surgical procedures that you're going to hear about, and also how standardization can make a big difference to outcomes. Sorry. I am a lecturer for ethical endosurgery and Karl Storz. I come from a very beautiful part of England, made famous by John Constable and some of the landscape painters. But I was very lucky to work with Roger Motson, one of the pioneers of laparoscopic surgery right from the early days. And this has enabled me to look at some of the barriers that he faced and so we as a surgical community faced. I think you are all very familiar with the innovators' laggards curve in terms of taking up a new surgical procedure. We have the innovators like Roger, John, Joel, and then we have a slow majority that adopts procedures, and this can be of a variable time. But what are the barriers to this adoption? Well, key opinion leaders can put up barriers with valid concerns, mostly about safety and cost. This can lead to regulation, and the whole process then slows down. One then has to meet the barrier of what local healthcare needs are. Does your healthcare system actually need laparoscopic surgery? Does it need expensive natural orifice surgery? And then, of course, we have to meet our own very human failings, we as individual surgeons and groups of surgeons. So it can take quite a lot to actually deliver change. I wrote on behalf of many of the associations in England and Wales a consensus statement on the uptake of natural orifice surgery. And if you were being negative, you could say that this consensus statement was a real barrier. I would like to be slightly more positive and say it was they were guidelines that protected the surgeon and the patient. But in colorectal surgery, and I'm going to stick to colorectal surgery this morning, adoption of laparoscopic colorectal surgery in England and Wales was very slow. In the mid-2000s, the uptake was around 5%, and that's based on hospital episode statistics data. And what we were being told by the key opinion leaders was that there was no training for this complex surgery, there were still oncological concerns, and there were concerns quite valid about the cost. And you have to remember what had been published by that time. Well, Antonio Lacey's trial, big meta-analyses, cost trial, the classic trial, and the color study, and many in the audience have taken part in some of these studies. But the great fear was that we were going to be like lemmings with laparoscopic cholecystectomy and encounter unregulated adoption by enthusiasts, no scientific evaluation, no formal training, and then result with poor outcomes. And so safety is a valid concern that we had. But you all know that in this country, the cost study with over 800 patients showed that there was equal recurrence in terms of oncological safety and equal overall survival. But in addition to this, there were many, many short-term benefits. So this led to the American Society of Colon and Rectal Surgeons statement, and I've picked out one particular sentence: laparoscopic colectomy for curable cancer results in equivalent cancer-related survival to open colectomy when performed by experienced surgeons. Now, we're in 2013. You have to realize this was back in 2005-06. We have a body in England and Wales known as the National Institute of Clinical Health and Excellence, and they did a technology appraisal on laparoscopic colorectal surgery and came to similar conclusions. Laparoscopic surgery was recommended if both laparoscopic and open surgery was suitable for the person and their condition, and that the surgeon had adequate training. And that's a very important point. What about finances? Well, every day you watch CNN or whatever news you have, and we have huge problems in the financial markets, and this has impacted on healthcare. There is political intervention with increasing costs and an aging population. The technology is very expensive, and this all feeds down to local financial pressures. Henry Dowson conducted a systematic review with the Guildford Group in the UK and published this study some years back, and showed that a systematic review of all the laparoscopic colorectal studies available, total hospital costs were about neutral. The operative costs for laparoscopic surgery are greater, the total hospital costs equivalent, and the indirect costs probably favor laparoscopic surgery. So cost in a mature system is probably an irrelevance. It depends on the system within which you conduct your surgery. What about local culture? Well, I could spend a whole day talking about human factors and the surgeon. How do we deal with change? How does a surgeon in their 50s take up laparoscopic colorectal surgery? It's hard. What are the perceived threats from younger colleagues and your practice? And how do you learn a new trick? So, looking at adoption, I think the key barriers are the opinion formers, cost, safety, regulation, local healthcare needs, and then your local culture. But once a procedure has been adopted, then there are huge benefits in standardization. And these are technical, outcome-related, and high-quality training. In England and Wales, the Department of Health and National Cancer Action Team, in conjunction with a group of surgeons, set up the National Laparoscopic Colorectal Surgery Program, known as LAPCO. And this was designed to train consultants or attendings, so senior surgeons, the guys who had to learn a new trick. There was about £6 million invested. It started about 6 years ago and was designed with a good infrastructure. There were 10 training centers. It was administered centrally by the Department of Health officials. There was local organization and administration of delivery. Trainers were selected very carefully. These people weren't coming to help your practice. The trainer actually had to deliver something. There was a very, very specific training the trainers course, so that training behaviors were homogenized, and the trainees were selected to give the best chance of a good outcome. We had one chance to get this right, and a research methodology was built into the program. So the format of the program, in order to achieve true standardization, was a pre-training information pack sent to the attending. There needed to be sign-up by the trainee's medical director in their institution. They needed the support of their multidisciplinary team. There needed to be a pre-training agreement, and then the surgeon had to invest the time to take their anaesthetist and theatre team to the training center to see how this procedure was conducted. The trainee then undertook 20 cases, either in their own hospital or in the training center. And there was a sign-off assessment based on videos that were submitted at the end of the program and global assessment score forms that were taken after each case. The assessment was coordinated by Imperial College in London. The global assessment score forms formed the currency for the training, and there was very, very good compliance as a result. There was also, very importantly, trainer feedback. So how did we achieve such a standardized training program? Well, that relied on a Training the Trainers course, and there are 3 centres there that run these at the moment. The training behaviours and methodology was standardised, and these are 2 of the most senior trainers in our country being trained on their teaching techniques. The Training the Trainers course is a 2-day course based in a dry lab and then in the OR. And the people being trained are not the people at the table, but the people wearing the mics. There is assessment of the training as we go along, and in-program quality assurance. And you can see this is the output from each of the training centres. So why supervised training? What is the benefit of this standardization? Well, you can see the yellow curve. That is a LAPCO delegate. They're being trained in laparoscopic colorectal surgery, and they achieve the performance standard in about 30 to 40 cases. If you look at the self-taught expert, the timeline is slightly longer, by about 40 cases or so. And there is a publication by George Hanna and his group from Imperial that looks at the proficiency gain. And essentially, those that have gone through a supervised program with expert guidance and feedback, performance assessment, achieve safer and faster training. So there are huge benefits in standardization. There are huge benefits in outcomes. The data actually shows that there have been well over 1,500 training episodes at the moment, with a small number of deaths, small number of leaks, and a small conversion rate. This is a national program. The adoption of laparoscopic colorectal surgery in England and Wales has gone to around 40% now. This graph is slightly old and doesn't have the 2012 data. So in conclusion, Chairman, ladies and gentlemen, I think the barriers to adoption are opinion leaders and their perception of safety and cost, regulation, the needs of the system, and local culture. Once one understands these, one can ensure that your procedure is taken up in a proper way. Standardization leads to better technical performance, comfort in the operating room, not just for the surgeons, but also the people who work with them. Outcomes are improved and training is improved. I'll leave you with this one thought from Star Trek. I showed you one Star Trek slide. My God, Jim, we can't leave him in the hands of 20th century medicine. Those butchers will use needles and knives to cut open his belly and chest. It is the Dark Ages. You have no idea what these barbarians will do. Thank you.